So, good morning, everyone. Sorry for not being making to Bombay due to flight issues. So, the topic assigned to me is about the concurrent chemotherapy in the role of limited stage small cell lung cancer. And I think so. Most of my talk will be more or less similar, the same trials as Dr. Doddle has already been discussed. But I will be mostly been focusing on the chemotherapy part of these trials. So, coming to the next slide. So this lung classification, the veterans, which is more commonly which we are using, what we see in this trial is the median survival. So the median survival for the limited stage is going something around 2 to 3 years, that is 20 to 30 months, and those with the extensive stage is around a year. And for 5-year survival is also only 20 to 30% for the limited stage disease as compared to that extensive, which is less than 5%. Next. The prognostic factor, what we see in this is the most common, I will say that now the limited versus extensive, because the median survival depends on these approximately 23 months versus 8 to 9 months. And there are many clinical factors which are being associated. The performance status is one of the things, the female sex, and something baseline LDH is also being reported in few trials, which is showing to have a prognostic impact on this. Next, please. So the role of chemoradiation in the limited stage, basically it comes from that there are many studies. So the Pignon meta-analysis has already been discussed, and after that the CTRT studies or the intergroup trial convert, and now the recent the CalGB. So I'll be focusing on all these which has now led to a role, and now the latest in this is the Adriatic, which is also coming post CTRT role in this subset. Next. So if we see the natural history, so there's as already discussed, it is the rapid tumor progression, and if we don't treat, the survival goes to 2 to 4 months. So in the initial years till 1960, both small cell and non-small cell managed similarly, either surgery or radiation. But both have got a poor survival in the small cell. And in later in 1960, that is a chemotherapy. Next. Next slide, please. Yeah, can you share the screen? Is it there? Okay. Yeah. Is it audible now, Nishan?
Yes, sir, audible.
Yeah. Think so. Okay. Just hold on. Okay, so the standard of care in this subset we say has already been discussed. Next slide. It is for the stage 1 disease. If we see, it has already been done. Surgery is the initial treatment. Just hold on. Yeah, surgery is the initial treatment in this subset of the patient. For the stage 2 onwards, so it's a concurrent CTRT or the PCI, and followed by consolidation immunotherapy, which is being not taken care in this subset of the patient. Next slide. So if we see, the whole crux lies in this slide for the treatment of the limited stage. So for primary, it's the 4 to 6 cycles of cisplatin-based chemotherapy, and followed by durvalumab maintenance now is the standard of care becoming. You can consider carboplatin if cisplatin contraindication is there in this subset. For radiation, it is twice daily dosing is the standard which has been approved in the clinical trials, but for most of the cases, due to logistic issues and other, is the once daily fractionation which we are using in our practice. And the RT should be started with either first or the second cycle of the chemotherapy, that is the best. If CTRT is not tolerable, in those cases, it's a sequential therapy we have to go. ERT. And for brain, it's a PCI is already being discussed. Next slide. So if we go to the both the NCCN, so for good performance status, it's the CTRT. For the poor performance status, it's the sequential therapy. That is, you go mostly with the systemic therapy and then after RT, or if the patient is seems fit, then going for concurrent CTRT. Next, please. So if we see the evolution of the chemotherapy for small cells, so it's initially it's a combination chemotherapy, then going to the single agent, there are many things coming. So the first standard of care regime was a triplet therapy which came in the late 1970s, that is cyclophosphamide, doxorubicin and vincristine. So around 358 patients were enrolled, and they have sequentially received here both thoracic and brain radiation. And the overall response rate for the limited stage was 75%, with the median survival going something around a year in this subset of the patient. Next. Thereafter, it was introduced cisplatin and etoposide, and it has been found this in the trial, in the phase 3 trial, that this regime is found to be superior to the triplet regime of cyclophosphamide, epirubicin and vincristine. The median OS with EP versus CVs was 14.5 months as compared to 9.7 months in the triplet group, and 2-year overall survival is around 25%, and the 5-year survival is 10% as compared to only 3% in the triplet subset. And there is no significant difference in the quality of life. So there is also a meta-analysis which also suggests that this odds ratio for the response is 1.35. So making cisplatin etoposide as the standard of care as compared to the triplet regime earlier. Next. So the next question comes, where to give cisplatin or the carboplatin. So if we discuss initially the Hellenic Cooperative Oncology Group trial, they have compared this carboplatin to cisplatin with etoposide. And the overall response rate in both the cisplatin and carboplatin is 76% as compared to 86% in the carboplatin now. The median OS was 14.1 months, but with no significant difference. So what we see is the toxicity difference are different with carboplatin and cisplatin. Though they are both efficacious, seems to be, carboplatin leads to more myelosuppression, while cisplatin causes more nausea, vomiting, nephrotoxicity and neurotoxicity. So it must be noted that, but the initial trials, that the most important, the intergroup and convert, all have used this cisplatin-based regime. So that's the standard that we are using. But if the patient is not fit, surely carboplatin. Next slide. So there is also basically a meta-analysis which has which shows that can carboplatin to be substituted. So this has included both extensive stage and the limited stage small cell lung cancer. And there is no statistically significant difference between cisplatin and carboplatin in this. The median OS is more or less same for the limited, 9.6 versus 9.4 months, and the PFS is also around 5.5 months. But as said, the toxicity profile are different in both with carboplatin and cisplatin, so you have to choose the regimen based on that in this this subset of the patients. So, but still, since the trials have used cisplatin, so it is still the standard of care. If not, then it can be safely substituted with carboplatin in most subsets. Next, next slide. Next. Yeah. So addition of RT. So this has already been discussed by Dr. Dodal that this addition of RT is beneficial to chemotherapy. This was the Pignon meta-analysis which showed that if there is an addition of RT, there is 14% reduction in the mortality rate, and the benefit in terms of overall survival at 3 years is something around 5.41% in this subset of the patient. Next. If we see, this meta-analysis has used multiple chemotherapy regimes, whether it's a doublet and a triplet, and all have shown the similar things. And if we go with the optimal dose and sequencing, so this meta-analysis hasn't shown any difference between sequential versus concurrent or early versus late. So all have shown a more or less similar. And if the patient is younger, they have a better survival according to this. Next slide. So sequential versus concurrent, already discussed, that is the Japanese clinical oncology group study, which shows the median survival is something around 19.7 months in the sequential arm as compared to 27.2 months in the concurrent arm. So therefore, concurrent is being preferred over sequential for the therapy. Next. So the twice daily RT versus single dose RT, so it has also been discussed. Next slide, please. So the intergroup 96 study, so this is an earlier study. It has been conducted in the year 1989 to 92, and it shows that twice daily is found to have a better survival as compared to the 5-year survival is 26% as compared to 16%. But the feasibility for this twice daily radiation has to be taken care. Next, there should be at least 6 hours gap between the 2 doses of radiation to make it comfortable. And thereafter come this CONVERT trial and the CALGB 30610, which have tried to prove that single dose RT is better in the CONVERT superiority, but it has shown that it's not superior, but it's definitely hasn't proved that it's not inferior. So still single dose is better. And whether you are going to escalate the dose, the CALGB has shown that high dose once daily might be slightly better in compared to the single smaller dose, but as compared to twice daily, it is more or less same. Next slide. So the feasibility is the one of the most important issue for twice daily, and the design of the trial hasn't made us sure whether it's a single dose RT is better than the twice daily. Next. So there is also that high dose versus standard dose twice daily. So in this, it has been shown that 2-year survival was significantly higher for the BD twice daily fraction as compared to the standard dose. For high twice daily, that is 60 gray, is better than 45 gray. So in this subset of the patient, so you have to treat this patient more aggressively. Next slide. For early versus late, so this topic has also been touched. So this trial was conducted in Canada by the NCI out of 308 patients. So they have used the triplet regime here also, cyclophosphamide, doxo along with VCR or as compared with EP alternatively. And they have given either RT starting at week 3 or at week 15. And they have shown that the median survival is 21 months if we started earlier as compared to 6 months if we started late. Next. So it has been shown in this meta-analysis also that early thoracic RT with cycle 1 or 2 improves 2-year overall survival compared to delayed RT or sequential CT-RT, and there is an absolute 5% benefit if you started earlier. And it is next slide. If it is, we see the benefit is more pronounced next also when RT is given either with a platinum-based chemotherapy or with an hyperfractionation. Next. Dose escalation. So I think so the next talk will be done by Dr. Ashutosh. So he will touching this topic of neoadjuvant therapies. So when to give neoadjuvant and then to switch over CTRT. So it's basically a phase 2 study which only showed that 2-year OS is 48% in this subset. So it will be discussed in further details. Next topic. If it So if it has been compared with the earlier, so it has shown that there is no significant difference whether you are going with a dose escalation or without dose escalation. Apart from what we see in the EP regime, that is the cisplatin etoposide. So what are there in the combination chemotherapy regime? So the initial studies were also taken care of epirubicin, and they have studied that high dose epirubicin in combination with cisplatin. In comparison to that etoposide regime, it has been shown that 51% of these patients has, out of this, the complete subset has a limited stage disease, and there is no difference in overall survival. That is around 10.1 months in the case of the cis-etopo arm as compared to 10.4 months in epirubicin platinum arm. And the overall response rate is also more or less similar, around 68% to 74%. So it has shown that the limited stage disease, there is a better overall response and better median slightly OS in the as compared to the extensive stage disease. But you are also seeing that epirubicin cisplatin experience less toxicity in this subset, only 37% as compared to 54% in those patients who have got received cis-etopo. So it seems to be a valid treatment option also for limited stage small cell lung cancer. But there is no large data available for this. Next slide. So there is other studies which used irinotecan initially. So Hans and colleague at Korea has the phase 2 study. They have used irinoansys as an induction initially, followed by 2-cycle induction by EP and with twice daily RT. So they have also shown that the median OS is something around 25 months and 12.9 months of PFS in this subset, and the side effect profile are more or less same in the subsets. Next slide. The other regime which they use initially for going for neoadjuvant, it is in the consolidation phase. That is, they initially use etoposys, and followed by etoposys, they have used that is the irinotecan based therapy. So consolidation IP after EP, and the patient receives after 1 cycle of EP, if there is no progression, has been randomized to either 3 cycle of EP or 1 cycle of irinotecan with cisplatin. In this trial also there is no difference in the median OS, and it is found to be a negative trial, to be frank. So still, because even after changing there is no difference, so still the standard of care remains to be cisplatin etoposide. Next. If we go for non-platinum, so if the patient is not fit, so if they want to do, so ifosfamide and etoposide was compared to EP in this with untreated small cell lung cancer, and 6 cycle of either are given. But in this trial, it has been shown that cis-etopo is found to be superior to ifos-etoposide in patient with a limited stage. The median OS is something around 14 months with cis-etopo as compared to 11 months in the ifos-etoposide. Next. If we further found to increase the chemo regimes, means the triplet therapy with ifosfamide, cisplatin, and etoposide. So there are few trials like Glasson and Hosier. So both phase 2 studies, they show that in this, and there's also phase 3 studies in extensive states combining all these three. They show that it is superior, they have a superior OS and time to tumor progression as compared to EP, but still all these are phase 2, and we don't have a clear-cut level 1 evidence to make them available for limited stage at present. So still might be we may be needing a trial to, if we further want to increase the intensivity of the therapy. Next. Taxane has also been added in this subset. So we combined paclitaxel with etoposide and carboplatin along with radiation. But if there are many trials, phase 2 trials have been done in this setting, but what we see that hematological toxicities were significant with this 3-drug regime, and it hasn't shown to improve any OS historically as compared to the intergroup and earlier studies. So it is not being used. Next.
Amit, I think you wrap up. We are overshooting time.
Yes, sure, sir. 1 minute. Just next. So the optimal number of cycles, 4 or 6. So the different trials show there is no difference between 4 or 6. Next trial. Role of growth factors. So this is also a controversial thing. So GCSF is probably safer than the earlier used GMCSF. So it can be used because of the modern radiation techniques with lesser risk of pulmonary toxicity. So you can use now GCSF also if needed in this subset. Next. So for going for the next slide, adjuvant therapy or maintenance. So maintenance chemotherapy has slightly beneficial, but it is in the large study, the data are low quality, so we are not using any maintenance chemotherapy, or interferon alpha, which has shown slightly benefit in this subset. Next. Immunotherapy, there are few ongoing studies with pembro in concurrent CTRT and with nivo EP post maintenance, and atizo with EPC CTRT. So the data are still awaited. Next slide. The data which came up now is for the Adriatic trial, that is the durvalumab as a consolidation, and it has shown the median OS as around 56 months as compared to 33 months of the initial therapies. So it is now the practice changing thing which will be discussed later. Next. Making durvalumab as a standard of care. Next slide. For older patients, geriatric, you have to see that there are more toxicities from standard therapy, but efficacy outcomes are similar. So if the patient seems fit, you can go with this therapy. Next slide. Real world data too shows that older patient can tolerate therapies if they are fit enough, and you can go with that. Next. So going to the next, so cisplatin etoposide and Sicians suggest this, and to conclude, we will say in the real world only 55% of the patients receive both CTRT, 20% receives chemotherapy alone, and the rest 3.5% receive radiation alone. So that's the real thing which happens with the small cell lung cancer. Yeah, coming to the last slide, please. Next. You can please next. So for chemotherapy, etoposide, carbo you can replace, and for radiotherapy as already discussed. With this, I like to, and sorry for the glitches, technical something happened. Yeah, thank you.